We're very happy and honored to welcome Bryan Ward, who's Associate Professor in the Department of Otolaryngology at Johns Hopkins Medical School at the Department of Otolaryngology. And he's going to speak on how MRI machines stimulate the vestibular system. So again, thank you for taking the time to join us today. We really appreciate this.
Well, thank you so much, Dr. Slattery, and for all of you for being here. I'm excited to be here. And Robin, it's great to see you again. Glad to see you're doing well. So I'm a neurotologist at Johns Hopkins. I spend the bulk of my time doing research on the vestibular system, and I'm interested in the causes of vestibular disorders and developing new imaging techniques and now temporal bone histopathology techniques to figure them out. And so today I'll be discussing a cool project that I think it's cool. It's been developing over the last decade or so, which is how MRI machines cause vertigo and how we came to understand the mechanism. And I appreciate it may be difficult to tune into a vestibular talk this early in the morning, but hopefully you'll find something interesting about the vestibular system. I have lots of cool videos, and hopefully you can explain to your patients what's going on when they're saying they're dizzy in an MRI machine or near MRI machines. So this is what I've been dealing with in the last evening. This is my dog, a 12-year-old Boston Terrier Ponzi, and my wife called me around 10 p.m. saying that the dog can't walk, and this is what his eyes were doing. So you can see he started to have this spontaneous horizontal nystagmus. The eyes are drifting to the right and beating to the left. He has this nice head tilt here, which indicates a right utricular hypofunction. So if you know a little bit about the vestibular system, you can diagnose your dog with a vestibular neuritis, or what they call an idiopathic peripheral vestibular disease. Just like in humans, we really don't understand kind of what's going on when people have vestibular neuritis most of the time. But you'll find yourself doing weird things like seeing how the nystagmus varies with gravity, trying to do head impulses on your dog if you know a little too much about the vestibular system. So the goals of the talk today are hopefully that you'll understand a little bit better that MRI machines cause dizziness in direct proportion to the strength of the magnetic field, that you'll understand the mechanism of magnetic vestibular stimulation, and also learn how strong MRI machines can be useful and why MRI-induced vertigo needs to be resolved. So I have no financial disclosures relevant to the presentation. The background for this starts decades ago. Technicians and people have been reporting sensations of motion around strong MRI machines for over 30 years. This was sometimes happening around 3 Tesla MRI machines, but it's pretty consistent around the newer, stronger 7 Tesla machines and even higher. There is a group in Florida called the Mag Lab, which studies these ultra-high strength MRI machines. And at Florida State University, Haupt and colleagues started putting rats and mice into these 14 Tesla scanners. So for reference, most of our clinical scanners are 1.5 and 3 Tesla. So this is a very strong scanner. And so when these mice would come out of the scanner, they would start to circle. And if you put them in water, you can kind of draw this out a little bit more. And interestingly, they found that if you did a chemical labyrinthectomy on the mice, so gave them bilateral vestibular hypofunction, this behavior was gone. And so they suspected that maybe the inner ear was related to this dizziness. So our story begins in 2010. David Z is an eye movement neurologist at Hopkins. He's my mentor, and he spends part of his life living in Italy, in Siena, Italy, or just outside. He was there in 2010, and he met this otolaryngologist, Vincenzo Marcelli, and they were talking about a study that Marcelli was doing, where he was putting people into a 1.5 Tesla MRI machine and looking at functional MRI. So functional MRI basically just shows increased blood flow to different parts of the brain, and you can get a sense of what parts of the brain might be stimulated with whatever you're doing in the functional MRI. And so what he was trying to figure out is what parts of the vestibular cortex could be stimulated with a caloric irrigation. And he had this curious observation, which he published in 2009, which was that in some of the patients or participants, there was a spontaneous nystagmus that preceded the injection of the water. So he was looking at the eyes closely in darkness, and he saw that there was a nystagmus even before he put water in the ear canal. And he thought that this might be due to the magnetic field itself. And so he brought this to the attention of David Z, and then he and David Z brought this idea back to Baltimore, where at Johns Hopkins we had just installed this 7 Tesla MRI machine. So at the time, this was one of the first, and now there are many, many of these. This one required its own building. It had to be built in a suspended room, so to minimize vibrations from the subway. But nevertheless, it was installed right around that time, and Dale Roberts is the engineer in David Z's lab. And what they started to do is put people into the MRI machine, healthy humans, and the key to figuring out what was going on was these goggles here. So they were trying to ask the question, why are people getting dizzy near MRI machines? And the key to solving the problem was eliminating visual fixation. There's a hallmark clinical rule in vestibular diagnostics, which is that a peripheral vestibular nystagmus can be suppressed if you're fixating. So if you're seeing something, you can suppress it. So my poor Boston Terrier is doing much better in the light than he is in the darkness. And in the darkness, with these goggles, you can see the nystagmus. So here's an example. So this is my eye. This is me going into a 7 Tesla MRI machine. And it looks dark to me. And you'll see in a second as I start to go into the MRI machine that I get this nystagmus. So my eye is drifting to the right and beating to the left, just like Ponzi. And I feel like I'm spinning. I have this sense, this strange sense of rotation. The rotation only lasts about 1.5 minutes, this is perception, but the nystagmus stays there the entire time I'm in the scanner. And the best way that I can describe the perception is this. As if you're kind of lying in the middle of a merry-go-round, like a playground merry-go-round like this, and your head is kind of spinning in this direction and your feet are spinning in this direction. It's a really strange sensation. But again, it only lasts about 90 seconds, but the nystagmus the whole time. So to figure out a little bit what's been going on, we just have to review some physiology. So how do we normally sense a head rotation? So in the semicircular canals, this is the horizontal canal just for orientation. If you accelerate your head this direction in a rotation, you're going to get a relative flow of fluid in the opposite direction. And that fluid is going to displace the cupula. As the cupula gets displaced, the hair cells that are embedded in the cupula get displaced, and that increases afferent activity in the vestibular system. So these canals respond to head acceleration, but the position of the cupula is a signal of head velocity. And so when you are doing a rotatory chair test, for instance, and you're spinning somebody in a constant velocity, what's going to happen is that initially that cupula gets displaced, but after a short period of time, the cupula will drift back into its original position, and eventually the nystagmus is going to go away. So in order to generate a constant slow phase velocity, you need a constant acceleration. So you have to have that cupula displaced the entire time. So when we're looking at these eye movement tracings, to quantify them, we look at an infrared video goggle. So the person is looking in darkness, but we have this infrared camera so we can see the pupil. And so we threshold the image, and what you can track is the black blob in the middle, which is the pupil. And if you just track the position of that pupil or blob over time, you get these traces. And these are the typical traces you see for nystagmus, where the eye is drifting in one direction and beating in the opposite direction. Drift, beat, drift, beat. And so there's this slow phase, and that's the part of the nystagmus that's due to the vestibular system. And then the quick phase is a rapid resetting. And so if you take the slope of the slow phase, you get a mark for how fast is the eye moving due to the vestibular system over that interval of time. So this is how we do caloric testing too. And so if you plot these slow phase velocity, you get pictures like this. So each of these little dots or circles represents how fast the eye was moving at that period of time. And again, it's just like caloric testing here. So, what I'm going to show you is just what nystagmus looks like when we plot it. But I first want to just draw your attention briefly to this green line. This green line is measured by a little loop of wire. And what we're doing is we put this little loop of wire by the person's head and we kind of introduce it into the magnetic field. And if you move a loop of wire through a magnetic field, you can induce a current in the wire. And why this is important to mark is for a long time, people thought that this was the mechanism that caused dizziness in MRI machines, which was electromagnetic induction. Because the sensation is usually transient. And so it was important for us to kind of measure the electromagnetic induction. It's also a really nice marker for when the person goes into and comes out of the MRI machine. So outside the MRI machine, there's no nystagmus, and then they enter the MRI, and then the nystagmus increases to a peak velocity. And then it starts to adapt. It starts to partially decrease, but it doesn't completely go away. And then when you exit the MRI machine here, you get this reversal, which is called like an after effect. And what you feel is that you feel like you're spinning in the opposite direction, and the nystagmus beats in the opposite direction. And how long this after effect is proportional to how much adaptation has happened in the MRI machine. So the first thing we did was we took two people who had no vestibular function, so bilateral vestibular hypofunction, and put them in the MRI machine, and we found that there was no nystagmus in any of the positions tested. So just like the healthy or the rats and mice that had no vestibular function, it seems like the same thing is happening in the humans. Okay, so if this is happening in the inner ear and you want to figure out the mechanism, you have to go through all of the different ways that magnetic fields might stimulate the biological tissues. And there's a few. So the first one, and the one that most people are familiar with, is this thing called magnetic susceptibility. So kind of like if you had a bar magnet and your bar magnet is attracted to iron. And so that is ferromagnetism, or ferromagnetic susceptibility. There's a weaker version of this called paramagnetism, which is a weak attraction. And then there's a weak repulsion called diamagnetism. So this is magnetic susceptibility. The second mechanism is electromagnetic induction. This is that Faraday effect, which I was just talking about with that loop of wire. And then the third class is something called magnetohydrodynamics, which is just the interaction of ion currents in fluids with magnetic fields, and it has two flavors. One of them requires motion, the other does not. And so we needed some strategy to sort out these mechanisms. So something dynamic obviously would require movement. Something static would obviously not require movement. And then some of the mechanisms are sensitive to the polarity of the magnetic field. So your bar magnet is going to be equally attracted to the north, or iron is going to be equally attracted to the north or south pole of a bar magnet. And others are going to be depend on the north and south pole. So the first clue was that the effect is static. So you have nystagmus the whole time you're in the MRI machine. So this is a 25 minutes in the MRI. The longest I've been in there was an hour and a half, and I had nystagmus the whole time I was in there. So it seems like it doesn't require movement for this effect to happen. It's also proportional to the strength of the magnetic field. So in a 7 Tesla MRI machine, it's roughly twice as strong as a 3 Tesla, and it can be seen in 1.5, but it's very weak, the effect. The third clue is that it doesn't matter how quickly you go into the scanner, how strong your nystagmus is. So if you go in really fast, you can get more electromagnetic induction, but it doesn't change how fast your nystagmus is. So it's not related to subject velocity. And then the final clue here in this slide is that for very short durations, there's no after effect. And that's because of this adaptation. So we'll talk more about that in a second. The most important clue that we had was this one. And so if you go in head first into the magnet, your nystagmus, at least in our magnet, was left beating. If you go in feet first, it becomes right beating. And then they let us go into the back of the magnet. And what happens there, if you go into the back of the magnet head first as well, the nystagmus also flips to the other direction. So it becomes right beating instead of left beating. And why that's important is it essentially rules out magnetic susceptibility. We don't think we have any iron particles in our inner ear. It can't be diamagnetism that's doing this. So it has to be sensitive to the polarity of the field. So the data shows so far that it was static. It was continuous nystagmus. It's not related to a transient induced voltage. It therefore can't be electromagnetic induction. It's also polarity sensitive. Reversing the magnetic field vector reverses the nystagmus direction, and therefore it can't primarily be diamagnetic or ferromagnetic susceptibility. Okay, so what do we think it is? We think it is this thing called static magnetohydrodynamics. So it's a fancy term that basically just means the interaction between ions flowing through fluid and magnetic fields. So if you put a charge in a magnetic field, you're going to get a force on that charge. And if you run those charges like through a wire and put that into a magnetic field, you get a force on the wire. Well, the same thing happens in a fluid. So in this case, for instance, if you had a charge that was running in this direction in the fluid, and you cross that with the magnetic field, you're going to get a force. And the way that this is represented is by this relatively simple equation. So the amount of force you get is how much current you have crossed by how strong your magnetic field is. And then there's this scaling factor, which is basically how long the distance is the current flowing. And the direction of the force is this thing that you may remember from a long, long time ago called the right-hand rule, where you stick your thumb in the direction of the current, your index finger in the direction of the magnetic field, and then that cross product is where the force is going to be directed. What's important to remember is that the force is in the fluid. So I'm going to show you an example of just what this looks like in a tabletop. So this is a saltwater bath, and there is an electrical current running across these two electrodes, and there's a magnet under the table. And so what you see is that there's a force that's generated in the fluid that's pushing this little marble around in circles. So this is what static magnetohydrodynamics or a Lorentz force can do. And so it turns out that the inner ear is really the perfect place for all of this to happen. So in your inner ear, you constantly have potassium entering into the apical ends of hair cells, and that sustains the resting discharge of the vestibular afferents. And so the potassium is secreted into the endolymph by these things called dark cells, and it develops a relatively normal concentration, and then around the apical ends of, for instance here, the utricle, it's going to enter or move in a consistent orientation. So what that causes is a net current vector. And so whenever you have a current vector and a magnetic field, you're going to get this thing called a Lorentz force. And it could, if it's strong enough, push on the cupula and cause dizziness. So the endolymph here serves two purposes. It transmits both the electrical current and the force. And those are the two key things that are needed for a Lorentz force to occur. So the key questions that we still had originally were, what's the source and the path by which you can get a horizontal nystagmus? And two, are the forces even sufficient to cause nystagmus? So the first is the source and path question. So you had to look basically back to anatomy, which is what can cause a horizontal nystagmus. So certainly the lateral semicircular canal can do it. The utricle is within the path, and some think that the utricle itself, when stimulated, can cause a horizontal nystagmus. And so we considered both of those structures, and that was where the original focus was. For the amount of force and whether it was sufficient, we just did a back of the envelope calculation. So how many hair cells? We have about 33,000 in the utricle. Each ampulla has 7,000. And then we know that the resting current for each hair cell is about 10 to 100 picoamps. So you can do the math to figure out how much force is going to be generated in a 7 Tesla MRI machine by this Lorentz force. And this is the range for the utricular current and the ampullary currents. And it was well within what had previously been calculated by Oman and Young as the amount of force needed to displace the cupula and cause nystagmus. So yeah, it seems like the forces are sufficient to generate nystagmus. For the directions, what we needed to do was to change one of the two vectors. We had to change either the magnetic field vector or the current. And it's really hard in an MRI machine to change the magnetic field vector. It's basically uniform along the center of the bore. But what's easy to do is to change the position of the head relative to the magnetic field vector. And so what I'm going to show you is here, one subject in different head positions. And you'll see that as they have this left nystagmus, and as they go inwards, it becomes less. So if they pitch their chin to their chest, it becomes less. And then there's this point here, this is called a null position, where there's no nystagmus at all. And if you pitch your head even beyond that null position towards your chest, the nystagmus will reverse direction. So if you look at the 10 original subjects, healthy subjects that were put into the 7 Tesla MRI machine, these are the different head positions. This is the intensity of the nystagmus, and to the bottom is left and to the top is right. And where it crosses 0 is the null position. So all subjects had a null position here. But what you'll notice is the range is quite wide by an amount of 40 or 60 degrees from subject to subject. And the nystagmus direction reverses whenever the null is crossed. So why would it reverse direction depending on head pitch? Well, that is because of this thing from the right-hand rule. So this was the original model of how this all works. If you have the magnetic field vector, which is shown in yellow, and you have a net current entering the utricle or the ampulla, if there's any difference between the angles of these two, then you're going to get that right hand that forces the fluid in this direction towards that lateral canal cupula. If these two vectors are aligned, there's no force, there's no cross product. And then if this vector flips and goes below this one, then the right-hand rule flips the other way, and you're actually stimulating the other direction, and that's how you can get a right beating, left beating switch. So this was the first hypothesized mechanism. It happened in all the humans tested and was absent in those who had bilateral vestibular hypofunction. We weren't alone. Other groups began to corroborate this. So this was from a group in London, finding a similar horizontal nystagmus that persisted in the bore and then the after effect once you leave. That group also did this really nice finite element model to show that the forces are sufficient to displace the cupula and cause nystagmus. And so it seems like other groups are finding this too. They continue to find similar observations as well. One of the things that we were really curious about was using this to figure out how the brain learns. So when somebody enters the MRI machine, you get this force that's like a constant acceleration, which is really difficult to do in any other way, because you can only accelerate somebody for so long before they start taking off. So what happens is you go into the MRI, and then you get this adaptation, and then there's this after effect. And so what's really cool is that you can manipulate this adaptation in some ways to figure out sort of what the brain is doing to deal with this constant vestibular stimulus. So this is kind of similar to what happens when we, for instance, like cut an acoustic neuroma, and you get the spontaneous nystagmus that then happens over time. It's important, though, to keep in mind, and this is true clinically too, is that there's a big dissociation between the nystagmus, which endures, and the perception of rotation, which is transient. So you'll often notice patients will adapt much better to the sensation of vertigo than they do the spontaneous nystagmus, which can persist sometimes indefinitely, as long as you're looking in darkness. So we took some people, some healthy humans, and we spun them in a chair at constant acceleration for basically as long as we possibly could. And we found that the pattern of nystagmus between the chair and the magnet was very similar. So it's like a constant acceleration. And just supporting some of the classic texts in the field that also did constant acceleration and saw this similar pattern of a peak, adaptation, and then after effect. So one of the questions I got pretty regularly was, okay, I put people in the MRI all the time. I've been doing functional MRI for decades. Why have I never seen this nystagmus? I'm always looking at the eyes. The person's always doing something. We have cameras there. And so one of the questions we wanted to look at is, well, what's the effect of vision on what's happening to this vestibular stimulus? So we know it can be suppressed, but does it really affect how the brain is kind of adapting? So we took some people, some healthy subjects again, and looked at their nystagmus outside the magnet, inside and out. And in one situation, we had the lights off the whole time. And then immediately afterwards, we ran them again and had the lights off. And then we turned the lights on just after they enter the magnet, and then turned them off again right before they come out. And so outside the magnet, there's no nystagmus, and then they enter, and then this nystagmus appears. And as soon as you turn the lights on and you fix on a little target, you can suppress it. It goes away. But here's the interesting part. So as you turn the lights off again, your nystagmus comes back. And it comes back to a level as if you had been in darkness the entire time. And then if you come out of the MRI in darkness, Essentially, it's completely overlapping. So what this means is that, yes, you can suppress the nystagmus, but you're not getting rid of the vestibular input. And the adaptation that's happening here is occurring before the eye movements or the eye fixation mechanisms have anything to do with the vestibular system. So it's probably occurring right in the vestibular nucleus. So it's not getting rid of the stimulus, but it is suppressing it. And this is relevant too for patients with like acoustic neuromas. You know, we know that head movements, for instance, are so important for adapting long term. But for that spontaneous nystagmus, it's probably happening, it's probably adapting regardless of whether the person's just kind of sitting there in darkness or not. It's really important for the brain to adapt to this quickly. So the first conclusion is that nystagmus in the MRI bore is explained by the effects of magnetic fields in the labyrinth, these things called Lorentz forces. And so now we have this mechanism, and we wanted to explore it by basically just challenging it. Like, can we try different humans, for instance, with labyrinthine deficits, or mice with genetic mutations, to see if our mechanism is right. And then we also wanted to use it as a research tool, for instance, in zebrafish. So the first was that humans who have peripheral labyrinth deficits. And this is one of the first humans that was had a vestibular weakness and was put in the scanner. And what you'll notice is that they have a horizontal nystagmus consistent with their asymmetry in darkness. That's expected. And then when they start to go into the scanner, something different happens. You get this, the eyes are drifting down and beating up. And we hadn't seen this in any of the healthy humans that we had tested thus far. So certainly a lateral semicircular canal can't be doing this. And I was a philosophy major in college. I'm really interested in the history and philosophy of science. And this guy, Karl Popper, was kind of one of my heroes. And his approach to science is that nothing in science, especially experimental science, can be proved. It can only be corroborated. You can find evidence to support it. But what you can do, and what you ought to do, is try to falsify your hypothesis. So you've got a hypothesis. You can say that your hypothesis is wrong. And so the question is, does vertical nystagmus falsify this hypothesis we had come up with? So to parse this out, we took patients that had unilateral vestibular deficits. There were 9 subjects, so 5 left-sided and 4 right-sided. They were well characterized. And what was interesting is that this is a left-sided subject here. And then green is the vertical velocity, blue is the horizontal. And so as they went into the magnet, just like the healthy humans, they had this horizontal nystagmus. But what was interesting is that they often got a vertical component. So in this left-sided lost patient, the eyes are drifting down. And if you look at all the left-sided lost patients, you can see that in general, these green lines tend to kind of hang out below. And if you go in feet first, at least in this person, it goes above. So it reverses direction, just like the healthy adults. And in the right-sided lost patients, the horizontal component was in the same direction as the left-sided, but the vertical component was different. So the right-sided lost patients developed a slow phase up, and if they went in feet first, it was reversed. So just to kind of show this a little bit more clearly, the right-sided loss tended to have a slow phase up nystagmus, and the left were a slow phase down. So we kind of puzzled over this for a while and went back to some of the basic anatomy. So this is a really good resource, the 3D virtual model of the human temporal bone from Massachusetts Eye and Ear Infirmary. It's a reconstructed pathology. And this is anterior and posterior of the right ear. The cochlea is here, the utricle, superior canal, and the lateral canal. And what I'm going to do is I'm going to take a look from the inside here. So you can see that this is the utricular macula in the reconstructed pathology. And this is the lateral crista and the superior crista. And we're going to swivel around posteriorly. And you can really see how close the lateral canal and the superior canal crista are to each other. So if you imagine that you have a utricular current that's constantly active, and you put that into a magnetic field, and it creates this Lorentz force in the endolymph above the utricle, it can displace the endolymph fluid, and it could potentially stimulate both the lateral and the superior semicircular canal, which are right next to it. So we thought that maybe the vertical nystagmus might be due to the superior canal excitation and inhibition, and so added this limb to the model. So how this would work is that for a left-sided loss person, what you'd have is you'd have this excitation of the lateral canal and an inhibition of the superior canal. And for a right-sided loss, you'd have the same direction for the lateral canal, but the opposite for the superior canal. It would actually excite the superior canal. And that would account for a slow phase down and a slow phase up. And in the normal situation where you have a functioning side both sides, the horizontal components sum and the vertical components cancel. And so that would be why in a healthy adult you wouldn't see the vertical nystagmus. But what was really strange is that if you do the kind of the calculation to figure out how the eyes ought to move, the torsion from these two directions actually would sum. And so what we wanted to do is we needed a better camera, and we needed to develop a special system to look at video torsion, twisting. And so Jorge Otero Milan, who's now at Berkeley, developed that when he was here at Hopkins. And this is an example of a healthy human now. And there's a really strange nystagmus. It's almost as if the eye is kind of swinging on a pendulum. So when you're used to seeing a post-op acoustic patient, the eyes are kind of moving like a wagon wheel. And in this situation, the torsion is the opposite of that. It's kind of swinging back and forth. And that might give you the same weird rotation sensation. Maybe that's why you feel like your head is kind of swiveling about your navel like that. It's really, really unusual. So the results from the unilateral vestibular loss patients and when we did this 3D matrix analysis of the eye movements were that the two canals that are being stimulated were the superior and the lateral canal, and by a similar amount. So not the posterior canal. So the next thing I did, this was during my T32 time in residency, is start putting mice into the strong magnetic fields and see, do mice have nystagmus in the MRI machine, and can we use mouse models to learn something about this? And so this is the sphere that was designed to fit in a 4.7 Tesla MRI machine. We 3D printed it and painted it dark so that it would be dark. And these are infrared LEDs. Charlie Della Santina lovingly called this the Death Star. And the mouse sort of slides in here, and it has a video camera right here that's reflected off of mirrors to look at the eye. So, and the mouse has to be fixed. It has to have a head in a fixed position. So here's what the nystagmus in a mouse looks like. And you see they also develop a horizontal nystagmus in a 4.7 Tesla MRI machine here. And there's a couple differences. One is it's a lot faster than in the human, and it starts to taper out over time, unlike the human. And that probably has something to do with the mouse's vestibular physiology. So we can quantify this mouse eye movement by putting these little markers on the pupil of the mouse. And if we know where these markers are and where the center of the eye is, we can do three-dimensional eye movement analysis. And so here's nystagmus quantified in a mouse. This is eye position over time, and this is like a horizontal nystagmus like the human. This is the velocity over time here, and if they go in nose first, the nystagmus beats in one direction. If they go in tail first, it beats in the other direction. So just like the humans, it depends on the polarity of the magnetic field. And then we took some mice that, so these were C57 mice, and we took some mice that had no otoconia. These mice are called head tilt mice because they have a head tilt, and they are deficient in something called NOx3. And what that means is that they don't generate otoconia, and so they have this head tilt, and if you put them in water, they can't figure out where upright is. They have to rescue them, so they don't have a functioning utricle. So we tested the mice first and figured out, yes, they definitely don't have any head tilt. We did horizontal rotations on them, and they do have a VOR. So here you can see their horizontal rotations to sinusoids. This is head impulses on these animals. We have a rotator that does this. And the NOx3 mice do have an intact VOR, but there's a slightly reduced gain. And what was strange is that they had no nystagmus in any of the positions that we put them into the MRI machine. So they definitely had a VOR, but they had no nystagmus in the MRI. And this is just kind of showing the C57s versus the NOx3 mice, really no nystagmus. So what this indicates is that you need a functioning utricle. You need that utricular current in order to generate the force that pushes on the cupula of the lateral and the superior canal. And we concluded based on the directions of the nystagmus that essentially the same mechanism was happening. But the canals themselves are not sufficient. You need utricular current. So the third conclusion was that mice also have vestibular stimulation in magnetic fields. Those that don't have otoconia have no magnetic vestibular stimulation. So the next question that was still during my T32 time came when John Carey and I were sitting next to each other at ARO. And we were watching a talk about high throughput screening of hearing in zebrafish, which are kind of a hot new model for all types of genomic analysis and drug screening. And he just leaned over and was like, can you put zebrafish in the magnet? Maybe we can develop a high throughput screen of zebrafish. And so I said, okay, I'll try. And so here's an example of a zebrafish in a cup outside an MRI machine. The zebrafish is about to go into an 11.7 Tesla MRI machine. And what you'll notice is that this is normal behavior outside, where they just kind of swim around the perimeter. But inside, they sort of flip and twist and turn the entire time that they're in the scanner. And this happened in about 2/3 of the adult fish that we put in the scanner. And if you notice in this fish, it seems to almost be diving down towards the center of the cup. And that's the direction of the magnetic field. So that's going to be relevant in a second here, just like that. So you can quantify this by kind of tracking it over time, and you can see obviously it becomes chaotic. It does okay afterwards. This is kind of what it looks like after. And so if you track the velocity, in both light and in darkness, the velocity increases in the scanner compared to after. An important thing just to remember is that in no time in any of these studies are we taking images. This is just the static magnetic field itself. So a question about the zebrafish was that salmon, for instance, have iron particles in these little hair cell organs along the side called the lateral line. And so so we had to do something to remove that from the equation. So we had them swim through gentamicin. And then when you do that, they don't really move in the cup outside the magnet, but inside the magnet, they definitely still flip and twist and turn. It's even more stark, the contrast between before and inside the magnet. And we showed that we successfully destroyed the lateral line. And so it looks like it is not related to these hair cells here that's causing that. So here's this is kind of a strange observation that we had, which is that we took those same fish and put them into a horizontal magnet. So in this magnet, they can swim wherever they want in direction with the magnetic field. And this fish is about to go into the scanner. And what you'll notice is that they start to develop a different behavior. So when they're in the scanner, they kind of have this darting behavior where they kind of dart in one particular direction and go slower in the other direction. And what's strange is that the fish has the same preference. So if you take this fish out and put it back in, it does the same behavior. But particularly strange is that different fish have different preferences of swimming with respect to the magnetic field. So some, like this fish, prefer north-south. Some, like these fish, preferred east-west. And then there were other patterns, or sometimes even no pattern. So they had a particular pattern. They were clearly sensing the magnetic field, but it's not clear sort of what they were doing with that information or how it was being transduced. So the zebrafish experienced profound behavioral disturbances in strong magnetic fields, and it was independent of vision and the lateral line. And the behavior, this rolling, twisting behavior, was consistent with behavior seen in adult fish with hair cell deficits and those who've had their utricles removed, or those who were taken into outer space in Skylab. So probably has something to do with the vestibular system. All right, so the conclusions from the basic experiments that we've done thus far is that MHD, these magnetohydrodynamic forces, stimulate the peripheral vestibular labyrinth, specifically the lateral and the superior canals. It depends on a functioning otolith organ. So we think that the utricular current is not what's being stimulated, but the utricular current is what's needed to generate this force in the endolymph to push on those cupula and cause the dizziness. And we can use this to develop new research tools. So why should we care? So this is where I want to talk about some of the kind of other things that I'm interested in, which is inner ear imaging. So what's the state of the art of inner ear imaging? I know this is not going to be or this is going to be well known to most in the audience. This is a flat panel CT scan, and this can give less than 0.2 millimeter resolution for bony structures. So really useful. We can see the stapes now. We can see really small dehiscences of the labyrinth, but really you can't see anything inside the inner ear. It just looks gray. So to look at soft tissue structures like this, what you really need is MRI. And this is the best, at least, that we have at Hopkins right now, which is a 3 Tesla MRI KISS sequence, which is used to look at anatomic imaging. So we can use this to see, for instance, the nerves of the internal auditory canal. But you'll see that it's not really good resolution, and there's some problems. So there's these banding artifacts that happen with particularly with the KISS sequences. Some institutions, yours might use space sequences, which are spin echo sequences, and they have their own kinds of artifacts that are slightly different. But the resolution is still not great for looking at kind of fine structures of the inner ear. I think the coolest thing that has happened in the last 10 to 15 years or so has been the introduction of gadolinium as a contrast agent for looking at the endolymph and perilymph as separate structures. And so this is good work, great work from Ishiyama, where what happens is if you give intravenous or intratympanic gadolinium, it does get into the perilymph, but not the endolymph, and you have to wait a period of time. So if you give an IV bolus of gadolinium, you have to wait a couple hours, and it seems like it gets up into the perilymph, but not the endolymph. And if you give it intratympanically, you wait 24 hours, and then you can scan the person. And because the gadolinium gets into these different structures, you can take advantage of the contrast, and you can design special pulse sequences that allow you to see the endolymph space as a dark kind of blob with respect to the brighter perilymph space. So this is a special sequence that also sort of gives a different contrast to the bone around so you can see the difference between endolymph and the surrounding bone. So this is great because now for the first time we can see hydrops in vivo, but you can see that the resolution just isn't quite there, and we need more. We need to do better. So one of the principles of MRI physics is just that the amount of signal that you have to detect anything is dependent on the strength of the magnetic field. So if you have a stronger magnet, you're going to have more protons aligned parallel or anti-parallel to the magnetic field. You get more signal. And so you can use that signal to get better images. So there are currently about 75 7 Tesla and greater scanners worldwide. And Siemens in 2018 has received clinical approval from the FDA to use their scanner for brain and knee images. And more recently, GE has gotten approval too. So, so these are inevitable and are going to be much more prevalent. And I think it's really important for a number of reasons. So in the vestibular system, when I'm seeing dizzy patients, we have all of these things that are essentially invisible diagnoses. They're inferred, they're based on eye movements. For instance, I saw in my dog that he has a right vestibular hypofunction, but I have no idea what's going on inside his inner ear. Same thing for people with sudden sensorineural hearing loss. So these are some examples where people have hypothesized that we have congenital absence of otoconia in some people, that you might have a heavy cupula or a light cupula, that you might have so much debris within a canal that you get a canal jam, that there's this thing called vestibular atelectasis, where there's a collapse of the membranous labyrinth. And all of these things are really great hypothetical disorders, but if we can't see them, then we can't really diagnose them. There have also been some surprises during surgery. So in, this is a great paper from 2017 from some patients of Parnes who had the posterior canal plugged, and he resected the membranous labyrinth. And what they found was this debris was actually a mixture of otoconia and really some of the otolith membrane, probably of the utricle. So this white chalky debris that kind of fills up the labyrinth. And it would be really nice to know ahead of time, before you get to surgery, whether something like this is present. There's this really cool case report from 2015 from Michigan, Steve Tellian, where this is a person who had this recalcitrant apogeotropic positional nystagmus, and they also had a loss of hearing in that ear. So they ended up getting a labyrinthectomy. And what they found in the labyrinth was kind of an interesting surprise, which was, you can see it, let me see here, kind of picking it out. We're going to show it here. Yeah. So it was this ball of granulation tissue that was sitting in the cupula. So the cupula had kind of become replaced by granulation. So you would imagine that something like this is hard. You obviously can't treat this with repositioning maneuvers. And it seems like it's isolated to a canal. So you might be able to do kind of a less destructive intervention. Or maybe it opens the opportunity for targeted steroid therapies. Who knows? But those are things that would be helpful to know ahead of time. MRI has this promise, and so this is a study from USC in which they took a human temporal bone and a guinea pig, and they put this in the scanner for, I think it was like 20 hours or something like that, and you can develop this almost histology level image here of the inner ear. So here's the histology, here's the MRI. This was a 20-hour scan that we did on a guinea pig, and you can see the cupula of the horizontal canal here, and the posterior canal here, and the crista, and the utricular macula. So it's in theory possible, but a lot of technology needs to be developed for this to occur. We also know, based on the talk earlier, is that higher field strength increases vertigo. So remember this equation where the force is proportional to the amount of current and the strength of your magnetic field. So it's twice the nystagmus in a 7 Tesla as in a 3 Tesla. When healthy people go into 7 Tesla magnets, over half of them report dizziness. And this is without any kind of preparation about what they're about to experience. They're usually in light and looking at a target. So it's a really common phenomena as you go to higher strength scanners. And it may have some influence on patient safety. So this is a patient at Hopkins who underwent this pituitary, who had this pituitary tumor removed. And on post-op day 1, they had their usual 3 Tesla MRI scan. And what they noted is that as they were coming out of the scanner, they felt like they were moving, and they got really sick, and they vomited in the MRI suite. And then immediately afterwards got a CSF leak. So they needed a lumbar drain. It eventually got better, and they went home. And when I heard about this, I called the patient and, with their approval, and asked them to come back and get a scan 6 months later in the same exact scanner. And I put some goggles on them. And what I saw is that if they really had very minimal nystagmus when they went in the scanner, but as they came out, they had this big after effect. And again, she felt like she was moving, but didn't have any nausea or vomiting. And so in the right vulnerable population, this could be an issue. And is worth addressing. Other things that this can affect is functional MRI. So I mentioned functional MRI has kind of started this story, but functional MRI also sort of relies on there not being much going on as a contaminant when you're in the scanner. And so particularly that's true for this resting state studies where people are basically just in there not doing much, and they look for these temporal associations for over long periods of time to look at what's the resting state of the brain. And so Rainer Bögl from Germany, from Munich, did this study with Mariana Dietrich where they were looking at fMRI in 1.5 and 3 Tesla scanners. And they knew that if the magnetic field, magnetic vestibular stimulation increases linearly with the strength of the magnetic field. But what's interesting is that the amount of signal from the fMRI, the bold signal, doesn't increase linearly. And so you can take advantage of that difference. And what they did is they put different seeds in parts of the brain that were vestibular related and parts that were not. And they found that those that were vestibular related increased linearly with field strength, and those that were not increased by this other expected ratio. So their conclusion from that was that a lot of resting state fMRI studies are going to be contaminated by this constant vestibular stimulation the entire time you're in the magnetic field. And the last part is this kind of neat thing, which is magnetoreception. So we know that animals use magnetic fields to navigate. We know that we have good evidence on homing pigeons and sea turtles and a number of other animals, but it's behavioral evidence. And there's this kind of fierce debate about what could be the mechanism by which animals are sensing magnetic fields. And so, for instance, in homing pigeons, the thought initially, there was like a high-profile paper in Science in which they might have iron particles in their beak, and that it's kind of mediated through the trigeminal nerve. There was another paper that said, actually, that's not true at all. You can find these iron particles in macrophages throughout the body, and so that's not it. In 2012, Wu and Dickman, who were at Baylor, put a electrode in the vestibular nucleus of these homing pigeons, and then they rotated a magnetic field around the homing pigeon. And what they found was here that they could find neurons in the vestibular nucleus that could detect both the intensity and the direction of the magnetic field. And so this was the first kind of neural correlate of a magnetoreception. So it's not clear still whether the information is being transduced from the vestibular apparatus or whether that information is kind of passing through the vestibular nucleus, just like lots of information can. But it's possible. And I think the important thing, though, to keep in mind is that the strength of Earth's magnetic field is orders of magnitude less than the MRI magnetic fields that we're using in our studies. All right, so my take-home messages are that MRI magnetic fields stimulate the peripheral vestibular system by Lorentz force, that the lateral and superior canals are stimulated, and that you need a functioning utricle for this effect. And that magnetic vestibular stimulation could be a useful research tool as a high-throughput screen, potentially to zebrafish, to understand how the brain adapts. And it's going to become more prevalent as we need and will develop stronger MRI machines. So I want to thank my funding agencies, the NIH, the NIDCD, the American Otological Society, and to Johns Hopkins as well. I've been very lucky to have an excellent group of mentors. Dale Roberts is the engineer who figured out this mechanism. Charlie Della Centina, John Carey, and David Z, as well as just a terrific group of collaborators. And so thank you so much for the opportunity to come and talk this morning.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.